Hi. So today what we're going to talk about is knee pain and then what we can potentially be able to do to treat it. So initially we're going to start off talking a little bit about the anatomy. Then following that we're going to talk about some of the things that can go wrong. And following that we're going to talk a little bit about what are some of the things that we could potentially be able to do about it. Today, most of the things that we're going to discuss in terms of the treatments are going to revolve mainly around steroid injections or replacement for the fluid that is contained within the element of your knee. So when you take a look at the knee is a fairly complex structure and it's comprised of a number of different bones. And so I'm going to kind of give you some of that medical background so you can be able to have a connection to understanding what it is that we're talking about. So as you take a look at this model that represents the knee, one of the things that we can see from this vantage point right here is the element of the femur. That bone is the thigh bone that is present within the component of your body as you obviously are able to bend the element of the knee, and it's the upper portion of the element of the knee. Additionally, you have the kneecap, which sits here connected in by a tendon and is able to be mobile to an extent and be able to move up and down. Lower down, you have the major bone, which we call regularly the shin bone, but in medical terms is the aspect of the tibia. And then off to the side of it is a smaller bone that's called the fibula. It's not as much of a weight supporting bone and normally doesn't factor into knee pain quite as much. In between, this blue structure, as you can see, is something that's called the meniscus. And so what we're going to do is take a look at a two-dimensional picture that's going to give us a little bit more depth and detail. So when we come over here and take a look at the knee, again, what we see is the element of the muscles of the quadriceps that are present that shield and overlay the element of the femur. And down here we have the head of the femur again. Here we have the element of the component of the tibia, or that shin bone as I referenced to you before. The patella, which is a cutaway and it's pulled down because we can see that it moves and it has this connection on both ends to tendons that keep it in place. The small fibula bone that I referenced to you before and how it's connected in by various different ligaments. And then that blue structure that was present in the model, that's the meniscus that exists here. And so when we take a look, if we were to take that knee and basically take it off and look down on a top end view, what we could see is the element of that component that's the meniscus. That's the cushioning that exists in the middle. And what it allows us, or allows the knee to be able to do, is to be able to be a shock absorber. So that when you walk and you have that compression that moves up and down, whether you have something on your back or whether you're pulling something up from the ground, that you can be able to have that cushion that's in place. So there's a number of things that can go wrong with this structure. And some of the things that we see when we get an x-ray or an MRI is that the cartilage that's present within this element starts to wear down, particularly over wear and tear of years or through exercise or potentially through trauma that might take place. The other thing that can take place is that there can be an issue that happens with the element of the meniscus, and where you can see not only an eroding of the meniscus, but a potential tear that takes place. And that can occur in multiple different spots, anywhere from the back portion of the meniscus to the front portion of the meniscus or off to the sides. And all those things can potentially be able to give you some degree of pain. The other thing that we have that we will assess with an MRI, but we can't be able to see with an x-ray, is the elements of some of the ligaments that exist, such as the anterior cruciate ligament or PCL ligament that exists behind it. You hear about it very commonly in athletes where you have a ligamentous issue that can take place and have a potential problem. So what are our major treatments for being able to help you have improved pain? The first of which is, after we know that you have an issue by looking at either an x-ray or MRI or combination thereof, what we do is we look to see if we can give you some medicine to help decrease the amount of inflammation and swelling that's present. So normally the way that we'll go about approaching it when we take a look at the knee is we'll use a live ultrasound machine that we are able to run over the element of the knee to see the femur, to be able to see the tibia, and potentially be able to see the element of the meniscus and the gap thereof. And what we'll do is we'll then take a small, and I do mean small, needle, and we'll insert it into the element of the joint. And we can see that injection under live ultrasound. So many patients ask me, well, why do we do ultrasound? There's a number of docs that actually just do it blind and that they get good results and it's worked well for me before. Well, there's a reason. Number one, because we want to make sure that we're specific and we're really on target. And number two, we've seen that there's been better outcomes. There's been a number of studies that have looked at injections into the elements of the knee and other locations. And what they see is blind injections are about a 60% success rate. An ultrasound guided injection of the knee is about a 90% success rate. So That's one of the reasons why we do ultrasound guided. It takes us more time to do. It makes us have to take it to a different location than the office normally. But those things are important because we want you to have the best success possible. So the first type of medication that we would inject, as I said before, was an element of a steroid. It's able to decrease the amount of inflammation that's present within the component of the knee capsule and the joint. A second type of medication that we can inject is something that's basically a replacement for the fluid that's present in the knee. And frequently, the way to be able to describe that the easiest is something that's called a synovial fluid. So if you were to take a look at this picture here, you can see a representation of that fluid being administered. Notice again, it's a small needle. You can barely see it. That what we're going to do is we're going to give you that medicine that's going to be placed within the context of the knee, and it's going to help replenish that fluid that's present in the knee and help coat that area so that you're not going to have the same type of pain that you normally would. The downside to this, as compared to the aspect of the steroid, is that we need to repeat this for 3 times over subsequent weeks, as opposed to a one-time injection, which was what we'd use with the steroid. So that's going to be something that could potentially give you longer lasting relief. The difference between the aspect of the steroid injection is it may give you relief anywhere from weeks to potentially as long as 3 months. When we're using this type of technique, it may give you relief as long as 6 months, if not longer.